going to just give you I'm going to give a whirlwind tour of my current research. I'm not going to dig deeply into any particular subject because I wasn't sure what would interest the audience. And also I'm involved in quite a variety of research. I don't have a strong sort of core topic. And well, so for that reason, I thought it would be more interesting to give you a little bit of an overview. So now that didn't go forward. Where's that? Okay. So I work in the ADAPT Center. It's a research center whose vision is a balanced digital society by 2030. Thought I should just give you a little overview of ADAPT since it funds many of my students. And the purpose of ADAPT is to pioneer new forms of proactive, scalable, integrated, AI-driven digital content technology that empowers individuals and society to engage in digital experiences with control, inclusion, and accountability. So you can see there are lots of words there which have been put together by the people who came up with ADAPT. In fact, not a whole lot of those words relate to my my research, although I'm involved with many people who are involved in AI and certainly integration. But the context of my work is the ADAPT Center. Retno gave a little introduction to me, but just to give you a bit of background, I did a computer engineering degree many years ago. I've been a lecturer, now called assistant professor in Trinity College, Dublin, where Retno did her PhD since 1990. And I have a strong interest in health informatics, and I lead the heterogeneity and interoperability challenge within the ADAPT Center. So the ADAPT Center has 3 broad strands, and each strand has 3 challenges, and I lead heterogeneity and interoperability, which actually is probably the most central part of my research. And over my career, I've been interested in clinical decision support systems. Patient-generated health data is a more recent interest, and broadly, a lot of my work and my collaborations have involved health data integration and interoperability, a very important topic in healthcare. So in the ADAPT Center, there's lots of an increasing amount of health research, that's because data fuels innovation in healthcare and health research, and we have strong background in data integration and heterogeneity, and of course data analytics is a big part of the ADAPT Center. We have a lot of good, very good AI researchers. This slide's a little bit markety speak, so I'll just move on, but just to let you know, there's a lot of this going on in my ecosystem. Okay, so I'm going to just start straight into one of the areas of research that I've been involved in now for 5 or 6 years, which I will explain using this slide. So this project was called AVERT, and it's about predicting the flare of vasculitis. So patients with vasculitis is a rare disease, and I work with a consultant called Mark Little, who is very interested in this disease. And the insight he has, and the one he came to ADAPT with, is that if we, let me go backwards. Vasculitis is a rare disease. It's difficult to cure it, but they manage that disease with quite a toxic cocktail of drugs. So it's a little bit like being on chemotherapy for longer periods than less intense, but longer periods than a cancer patient might be. And the patients are on these drugs to prevent flare, also known as relapse, of the disease. So if we could predict flare, if we could understand what causes flare of a patient, that's over here, this patient is trundling along and working towards flare. If we could understand flare of the patient, if we could predict the flare of the patient, then we could vary the drugs that were given to the patient, giving him less or no drugs if there wasn't a flare on the horizon, and giving more if there was a flare on the horizon. And we don't understand terribly well what causes flare of vasculitis, but it is believed that there are environmental factors which contribute to flare. For example, weather, pollution, bugs, infections, and so on. And the insight of this project was if we could understand where vasculitis patients are, and that was to be done using a patient empower app, which the patients would use to track their activity, what they've been doing, how they're feeling, but also, and importantly, their location. The insight we had was that we could then use the location information to determine the weather and the pollution and maybe outbreaks of bugs in their area. And with all of this information integrated into one resource and using machine learning, statistics, whatever tools we have available to us, we might be able to predict the flare of the patient and, understand better flare, and then ultimately build prediction tools for use in clinical care. Now, this has been going on for quite a while, and we haven't been as successful as we'd like, and various things of interesting things have caused difficulties. One of them is that while patients were willing to share their location over the course of a day, many times a day, in theory, they're willing to do that because these are patients with rare disease who really want to understand and to help understanding of that disease. In fact, the technology made it more difficult for them to do so. If you want to keep tracking location on your phone, you have to have location services on. It takes up more battery. In other cases, these patients were not always technically able and weren't able to turn on location. So we actually collected location less often than you might expect. And the other thing that was more difficult than we anticipated was getting local pollution data. We had some ideas about this. We had colleagues in the university who were developing various localized models of pollution based on land use and other things, but in fact it was very, very difficult to get these models to work with our data. Weather was more not easy, but a lot easier. And we do have information about outbreaks of diseases, of infections in the country, in Ireland. This was all in Ireland. So this wasn't a totally successful project, and we've moved on from this project. But what it did allow us to do was to think about the integration of the information. Sorry, I forgot to mention, of course, that there's disease registry information about these patients is held in a rare kidney disease registry and biobank. So we were integrating that data with this other data, and we worked with a lot of statisticians on this problem. So what this project did do, even though it wasn't entirely successful, is it brought together a variety of multidisciplinary researchers to work on this problem of vasculitis and vasculitis flare, and that has been beneficial. There was one paper that came out of that research, which relates to the role of UV light on vasculitis flare, which I haven't mentioned here. Okay, then as I said, this project brought us to together, and we're now envisioning the next phase of this research in this way. Now, there's a lot going on in this picture, and in fact, I didn't draw it myself, and I'm not going to tell you everything, but the general gist is the same kind of problem. Patients are diagnosed with vasculitis. They're on induction therapy. That finishes off typically about 6 months, and it's in the maintenance therapy stage that we're interested in exploring. We're interested in flare risk. So really, this is the core of this project, and the question is whether to continue therapy or wean therapy. So the same principle as before, and things are happening on a time scale, which makes data analysis more complex. It's time series data, and the project we have a lot of information. This is the again, the registry that I mentioned earlier, it happens to be in a system called REDCap. We will continue to have, and we do continue to have, data coming from the patient, from the app, and we have a richer, in this project, a richer set of biological information about the patient. We're bringing in partners who can analyze various kinds of biological markers of illness or health or whatever to this project. So my involvement in this phase of the project will be at this integration tool stage, trying to understand how to combine and to integrate all of these data sources. And so more generally speaking, this has brought us, me and the team that I work with, has brought us into an area called clinical research informatics, and certainly that's what I'm calling it. And it's amazing when you start to work with people in other domains, you discover that they, for example, they work with multiple Excel spreadsheets. That's their way of working. They haven't got better ways of handling data. They obviously that data often ends up in R, and they use R to do modeling, but the data that is passed around and integrated is captured in Excel spreadsheets frequently. We're just poor for managing provenance. Where did this come from? How do I track back and do reproducible research, which is very important in this area, in this age of research integrity. It's hard to integrate multimodal data because Excel spreadsheets don't really do multimodal data very well. And there's a lot of multimodal data in healthcare. And the data protection is a bit ad hoc, right? Who has the Excel spreadsheet and what have they done with it? It's all a little bit hazy. So in the AVERT project, the first one I mentioned, in the Paradise project that's coming on, and FairVask, which is in the next slides, we're using a semantic web technologies approach to this problem. So the first aspect of that is ontologies. We are modeling the kinds of data which are relevant in this area using semantic web tools and ontologies. And then we are representing the data itself using knowledge graphs. Those are triples, subject, predicate, object triples. And then going through an integration process. I'll show you a diagram of that process that we're using in the FairVask project in a moment, which involves harmonization and of terms and so on. And then one of the difficulties, this is one of the areas that hasn't been successful yet, and we're working on, is providing intuitive access to the knowledge graphs, to the data in these knowledge graphs for clinician researchers. So they have their Excel spreadsheets, they like them, they know them, they understand how to deal with them. We as informaticians understand the limitations and they're not even just limitations, the issues, I guess, with spreadsheets. But on the flip side, when we move this data into a more, computer science approved way of doing things, it's actually quite difficult for the clinician researchers to access that data. So there is a stream of research going on now, which is I'm not directly involved in, which is trying to improve access to knowledge graph data for these clinician researchers. There are general purpose tools for browsing, wiki data, Wikipedia, Wikidata, just Wikidata browsing tools, but those are not appropriate for this kind of more structured data. So that the work we've been doing in vasculitis has the biggest activity, because this was a funded project which has been going on for 2.5 years, is FairVask. And the FairVask funded project is working with registries across Europe. So these are it's all vasculitis still. We're still interested in understanding, well, in fact, in this case, understanding both onset and relapse of vasculitis. But in this case, we are focused on FAIR being findable, accessible, interoperable, and reusable data. So the FAIR in this context is that acronym. And what we're trying to do here is to combine. Right, so I should stand back. Vasculitis is a rare disease, and therefore we don't, in any one country, or particularly a small country like Ireland, which has a population of 4.5 million, we don't have very many vasculitis patients. It's a few hundred patients. And so to do any decent analytics and prediction and so on, we really need more data from more patients. And generally speaking, even if you're not doing prediction, you want more data. So the idea here is to combine information from multiple registries. And in this case, we have seven in the beginning, 6 who are contributing. And we want to be able to issue queries against this combined data, but to do that in a way that protects the data of the individuals at the various different registries. So in the FairVasc project, I'm not going to go into detail about how we're doing the federation, but in the FairVasc project, no subject level, no individual level data leaves the registry sites, leaves the other countries in Europe. When you issue a FairVasc query, the query is sent to the various registries, and they generate aggregate results for that query, and that's what's sent back. And there's a limit to how small the aggregation can be. So if you ask a query and there are only 2 or 3 cases in any registry, then that registry will not return that data, because that would compromise the confidentiality of the data at that site. We in Europe, as you probably know, have something called GDPR, General Data Protection Regulation, which is very strict in how we can use data. And even though patients, generally rare disease patients, are happy to share their data because they want to help solve the problem of their disease, we're not necessarily allowed to do that, even if they in principle are happy to do it. This project also provides an opportunity to explore issues of findable and accessible data in a world of general data protection regulation. And also this project, which is not represented on this diagram, allows us to explore, and we have a strand of work exploring federated learning. So how can you how can you distribute learning algorithms across multiple sites? But that's not my area of expertise, so I won't say any more about it. I'd say a little bit more about data integration process in FairVasc, which I've been more involved in. And this has resulted in a paper with my name on it. Some of the other papers from FairVasc don't have my name on them. And so what you have to think about in FairVasc, we're working with clinical research teams at 6 or 7 sites. And each of them, while they're all representing information about vasculitis patients, each of them does that in a different way. Each of them has different data. And so we have to do a harmonization job, because we want all of the data in the, we're just going to go back one step. I didn't make it clear here. If this is the local, if the local existing situation is in these squares, what's happening at this layer here is that the data from each of these is being turned into knowledge graph format, triples, and these triples are then what is, these triples is what is being accessed, but these triples each sit at, these triple stores each sit at the separate sites, but this is the triple store. So what's happening on the next slide is I'm describing the process that we've gone through to work out how to turn the registry data into harmonized FairVasc data. Okay, so we have a harmonization implementation team, and so the word implementation is a little bit lost there, but harmonization team, which consists of the clinical researchers, the people who understand what the data means and how that data might be harmonized across various registries. So for example, I'm not going to come up with a good example now, but if end stage kidney disease is an important concept, but that concept is represented or considered differently in different sites, we need to decide what is the FairVasc meaning of end stage kidney disease. So that's what these people are doing. And then that is handed on to the FairVasc implementation team. And these people here are then worrying about, well, how do we take the ideas and the agreement that's happened at the harmonization stage and turn it into ontologies and mappings, which are the way in which we turn actual data into ontology representations. And then the query implementation team is the people who are then saying, if we have data represented in this format, how do we implement the queries which the clinical researchers have come up with? And in fact, I should have started here, because the driver for what are we going to try and harmonize, the driver for that is, what are the queries which clinical researchers would like to be able to issue against the data in the FAIRVASC world. So this process is the bulk of the work in this FAIRVASC project. And, you know, as you'll tell from that, we're not really answering any scientific questions there. We're just setting everything up for the scientific questions. Okay. This work I've been working on in vasculitis has led to an interest in motor neuron disease, also known as ALS. I can't remember what ALS stands for, but it's an unpleasant disease, which a neurological disease, which has from diagnosis to death is typically about 3 years. So it's a rare disease which kills people. And we have a large body of work going on here with a bunch of many pharma companies, because they're really interested in understanding this disease and how they can treat it. And I'm not going to say too terribly much about it, because I've spoken for quite a long time. Actually, I don't know how long I've spoken for. Yes, too long probably. And so I'm going to skip over it. But the point of mentioning this is that the work on clinical research informatics that began when Mark Little came in and said, I'd like to track patients going through space and time and understand how that feeds causes the flare of their disease, has led us to a very strong stream of work in clinical research informatics. Okay, and obviously my involvement in that is at the area of how we're going to actually handle all the data, and there's other stuff going on there. So using similar techniques, maybe or maybe not using semantic modeling, managing identities and so on. Okay, other areas of research that I'm interested in, and I see now that I've probably spent longer than I should have on the early part of my presentation. So another area of research that I'm interested in is patient-generated health data. And my interest in this began, this is a photograph of somebody's elbow, I think, where they have, I think it might be eczema or psoriasis. I should know, but I don't. I just took the picture off the internet a couple of days ago and have forgotten. But the point of my interest in patient-generated health data is that when patients with chronic illness or chronic diseases or just conditions like this skin condition, between visits to their doctor, in the case of the first picture, their dermatologist, there can be many changes and phases of their disease. A dermatologist I worked with in the health informatics MSc was interested in capturing what's happening for the patient in the middle of the month, between when I see them and I don't see them, and what's going on in their life at that stage between the months. So there's actually a parallel a little bit with the AVERT project and the impact of things in your life at a particular moment in time causing a flare up, in this case, of this disease. But to do this well, we need patient-generated health data. In other words, we need patients to be able to capture data about their health and well-being, and to provide that data to their clinician. And I'm interested in where this patient-generated health data, obviously watches and wearables and medical devices such as blood pressure monitors are all part of this world of patient-generated health data. I'm interested in where this becomes part of the clinical decision making, right? So obviously we all can use wellness tools for our own control of our own disease, and that has a role, but I'm interested in, well, what happens when this stuff, this information, this deluge of information meets clinical decision support. So there are lots of issues that are of interest here. I'm going to mention 2 PhDs that I'm working with at the moment that are interested in this. One of them is interested in trust. I'm going to say a little more in a moment, but there are issues of data quality. Where did the data come from? Data provenance, governance, governance in lots of ways. But one of them is, if a clinician is going to make a decision based on patient-generated health data, that decision the basis of that decision needs to be recorded somehow in the patient record, right? So that's how medical work works. We need a when the insurance companies, when they're sued, when there's a problem with their delivery of healthcare, they need to go back to the records and say, this is what I knew at this point in time, and this is why I made the decision I made. So if they're going to use patient-generated health data, which seems like a sensible thing to do, they need a way to incorporate appropriate parts of that data in the record. And that's kind of the interest that I have in this. So one of my PhD students at an early stage is interested in how we can exchange contextually relevant patient-generated health data with the electronic health record, the actual record that the patient, the clinician uses, using well-developed standardized information models. And this has not been well developed. It's happening in specific spaces for specific kinds of data, but it hasn't been done in any great way. So this student is working on trying to understand categories of patient-generated health data and how they might be, what we would want to have in the record and how that might be represented. And then another of my PhD students is interested in how can the relationship between quality, provenance, and risk to the patient be used to make the right decision whether to trust or not trust patient-generated health data. So he's interested in clinician trust in patient-generated health data, and where trust is an issue. You know, will I use this kind of data or not? Will I pay attention to what's coming from the patient or not? He's interested in these areas of quality, provenance, where it came from, and risk to the patient. And this is he's in fully interviewing clinicians at the moment to understand these issues. Okay, I have another PhD student who's been very busy and very effective publisher, and most of my publications in the last year have been because of this student. It's a little bit off topic from the rest of what I've been talking about, but I'm just going to give you a very quick introduction to what he's interested in, and that is user engagement with mHealth. So this paper that I've cited there, he studied literature and came up with some themes around this area of the difficulties, the problems with mHealth and user engagement in mHealth, and established that there's a need for framework for designing for user engagement. So really trying to understand much better users and what they need from mHealth. And so it's a form of user-centered design, but on speed, right? Adding extra layers to how to do user-centered design. And so just as an example, this is a sort of a mock-up of not even a mock-up, but it's beginning to try and help designers of mHealth to capture much richer information about the social and political and contextual and whatever else information about a user model. I should have said at the beginning of this that we're interested particularly in mobile health in developing contexts. In this case, we're working in Sierra Leone. My student is from Nigeria. We're interested in the fact that, and I think it said it on this slide, adopting mHealth designs from global north settings, number 3 here, to global south settings is not working as well as you might like. So these tools that he's bringing to this framework are designed to capture the differences between people in different countries. And so, you know, one of the things that happens is a system that's designed for and works very well in Bangladesh doesn't work well when you bring it to, for example, Sierra Leone, because there are strong cultural and social and political differences in those contexts. Okay, I'm finished there. I'm happy to take any questions. I think I'll stop sharing so I can see your faces. Yeah.
Okay, thank you, Professor, for sharing. I think there are 2 interesting topics in your research talk. First is about vasculitis diseases and building predictive modeling to guess when the flare will be coming based on the location, weather, and demographic factors. And the newest one is about patient-generated health data with aim to make appropriate clinical decision along with the EHR data used by clinicians. So those are very interesting research talks. And I think now we're going to the next speaker. Or do you mind if we have Q&A session right now?
Please just continue with the question and answer, I think. Hello, Professor
Okay.
Lucy Hederman. Sorry, I'm a bit late.
It's okay.
Okay, thank you. Now we are in a Q&A session. All participants are invited to raise hand if you have any questions, or you may leave text in the chat box and I will read it for you.
No questions.
So is it response or Q&A or comments or feedback or something?
If anybody wants to follow up with me, Retno obviously has my email address. I didn't put it on the slide. I forgot to.
Yeah, sure. Okay, so this is Rani Klarina.
Yes, thank you for the very interesting talk. Honestly, this is not really my field per se, but I think it is interesting since one of the priorities of the Indonesian government in its artificial intelligence policy is to apply artificial intelligence for health informatics, and it's very interesting that you have many areas of many particular researches, which I think it's quite practical. What I'm curious about, I do have some experience in working with health data, but it seems that it's very difficult to have get the relevant data for issues that you have mentioned. First is since it's scarce, and also for the privacy issues, and especially about privacy issues. Now, how do you decide what kind of topics or maybe projects that can be done, that is feasible, that is doable, since AI basically fields of data, so data is everything.
Yeah.
So, yeah.
So it's a really good question, and as I said, the vasculitis projects came to us. Mark Little, the consultant who's interested in this topic, came to us, and he had his data and he brought it to us, and he was keen, and he's very keen to share that data. And the data is pseudonymized, it's coded, so the registry data is coded, but we still have to worry about identification, because of course with a rare disease, as I always say, in fact, my husband's uncle died of vasculitis a few years before, well, about 2 years before Mark Little came to me. So my husband's uncle's record is in there, and without any, even without any identifying name, address, whatever, if I know the day he died, and perhaps if I knew the one visit of his clinic visit, I could find his record if I wanted to. So it's a huge issue. So we have to explain to everybody who is involved with this data how careful they need to be. The precision ALS, the motor neuron disease, similarly, because it's a rare disease, patients are very keen for research to be conducted, and the clinician, the chief clinician in Ireland who deals with this disease came to us, so she's bringing the data to us. But I have another PhD student that I didn't mention, who was planning to do, I'm not going to go into what she's doing, but she was planning to work with physiotherapy patients. You wouldn't have thought that there would be a huge issue about privacy, but the physiotherapist who worked with us for a year then decided that he wasn't going to proceed because he wasn't sure he could share the data with us. It's not great. And then we started working with an ICU specialist who absolutely promised us that he had the data, that he could give us the data. In fact, he gave us the data. And then we discovered that actually he didn't have the proper, appropriate permission to give us that data. And this poor PhD student is really suffering now because that data has not come through to us. And now we're having to look at an open data set that is not easy to get, and is not as suitable for her research. So it's a huge problem. And I wouldn't recommend beginning with, oh, I'd like to do AI in health research. Let me go find some data. I think you really need to respond to people coming to you. But if you do, just be very, very careful. There are open data sets. There are, that might be a way of proceeding, but it's highly problematic, is all I can tell you.
Okay, but I think it's then it is very interesting that people actually come to you and they have, usually people from the health domain, physicians and so on. I don't know, they don't really know what we are capable of doing and things like that. So how do you communicate with people who might have relevant data and relevant permission, so that
how do you communicate? That's a big part of my job. I find that the role I play in many of these projects is sort of sitting between the clinicians and the health and the because I've been in this space for a very long time. I find myself, actually, a lot of what I do is saying, and now hang on a second, what he's trying to say is, and what you're saying is, and that's not, you've misunderstood each other, and aligning people's conversations. Mark Little, the expert in vasculitis, who's a really, really good person to work with. And, if you're getting into this multidisciplinary sort of field, he's an exemplary kind of person, because he cares about our research. He actually cares about us getting a health informatics publication from what we're doing, and being able to explore ideas that matter to us. Look, for example, federated learning for the people in that area. But that's not true of the clinician for the ALS motor neuron disease, who really just cares. And you can't blame her, right? All she cares about is answer my research questions, solve my problem, do it as simply as possible. And I don't care how that works for you, but that's not very effective for us. Anyway, so that's about communication. But yes, how do you even let health people know? Well, what I'm finding is that increasingly clinicians, research clinicians, I mean, these people are all working in the university. They are clinical researchers. They are hearing that, that AI should be able to help them. They're hearing, in their own worlds that AI prediction, clustering is the way forward, and they're looking forward to that. So that's how that's been happening. Even in the case of the ICU doctor, who in fact can't give us his data, he kind of came to us saying, I think that there are ways in which we should be using AI.
Okay. So that's so if I may, conclude maybe talking to somebody or some people in the health domain who also works in university might be easier.
Yeah, no, I think that that's an important thing to do. I think that makes it easier. They're more likely to understand research integrity. You definitely want to be working with researchers, because what you really want is a collaborative arrangement where they will get publications, forward their career, and you also will be able to do that, or enjoin publications. Doctors who are not working in research are less likely to have that objective, and I think it's more difficult to work with them.
Okay. Thank you, Dr. Thank you so much.
Okay, thank you, Mrs. Rani Pradina and Professor C. Hederman. I think this is the end of the first research talk session. Now we're going to the next research talk from Ibma Hendrawati, PhD, who is head of Enterprise System Laboratory in IS department. Her research is business process management Supply Management Enterprise Resource Plan. She is also an author of Business Process Management book. Ibnu Hydrawati, time and screen are yours.
Thank you, Bu Retno Aulia Finarti. And so I would go straight to my presentation. And I'm sorry that I didn't follow your proposal to talk about my latest paper, but rather than focusing on one paper, I would like to talk about the roadmap of my research, because it is something that is evolving all the time. So let me start by explaining how I get here. So in 1995 until 2004, I was an industrial engineer. So the research that I've been doing very much relate to, for example, when I was in undergraduate study, I try to measure the productivity of garment in Bali, because that's how I can get the data. And then in my master degree, I try to research. It's not a research because it's more like a mini project. It's only 3 months. And the topic is on agility in the new product development process. And then for my thesis, I work on product variety in international supply chain. So everything is related to industrial engineering field. But then I become lecturer in information systems, and then I teach SCM, supply chain management, which is my background. But then I also start teaching CRM and then ERP. And finally, I taught about business process analysis, and then it becomes business process design and management. And finally, in the last curriculum, it becomes business process management. And this is how I get to realize the meeting point between my background as an industrial engineer and the place where I work now, that is information systems. But my research has been quite colorful. So I would like to share it with you all, because you are in the beginning of defining your research, which I think very much depend on how you set your end goal. I began, so this is quite interesting, because I start with doing research in healthcare information systems, because at the time the department have a project with Kumamoto University under JICA. So then I carry on with logistic information system, and then hospital information system, etc. Then I also studying doing process mining, and then business process management. So the journey has always quite, I wouldn't say straightforward, because there is a time where I try to have more IT-oriented journey. That is the period where I tried more on the information system side. But then I realized I would only be the project manager, because I don't really know how to create or develop the software. Then evaluate the business process, but from a quantitative point of view, using process mining. So business process versus data analysis. Then the BPM journey actually started, because I realized that although these companies has implemented information systems, even the most complex information systems, the most integrated one, like enterprise resource planning, they are not necessarily managing their business processes. In fact, their implementation of information systems are more like forced, because of the regulation, because of they wanted to be competitive, because the competitor has it. So there's no underlying needs to conduct the business, to automate the business process and manage it. That's how I'm I changed a little bit from the other end of the spectrum, analyzing the data, but more towards the fundamentals of why these companies need to do automation. Is it really necessary? And so I tried to create this definition. So I know it's a very big words. There are so many things under one definition, but business process management is a discipline that combines modeling, automation, execution, monitoring, evaluation, and optimization of business activities to support an organizational goal within the boundary of organization and systems involving employee, customers, and partners across the supply chain. So actually, when an organization is trying to improve their business process, they need to do it holistically. It's not supposed to be a one-off thing, and implementation of information systems is only one aspect of the entire cycle. Then I also this is one of the paper that I published in Business Process Management Journal. It's basically trying to make sense of how this organization can compete in the competition today. So when we are looking at an organization, sometimes we only look at what they are doing, but actually what the organization is supposed to be doing depends a lot on the competition and whether they are competing in the industry where the product substitution is a lot. So they need to be always competitive, and they also pressured by the supplier and customer. So this actually define how they should react. Then within the organization, they need to have alignment between the vision, the strategic objective, and how they measure the achievement of this strategic objective through process, and then the structure, having the correct people to conduct the process, and also then finally having the information systems that will support these people to do their job and task to achieve the goal. Now, these days, with the advance of information technology and how the business environment have evolved, the volatility, the uncertainty, complexity, and the agility of the environment, it is not possible for one subject to tackle every problem. So I came across, again, another evolvement of business process management to become process science. So process science is the interdisciplinary study of processes. That is a sequences of actions and events which take effect over time and in context, aiming to understand, influence, and design processes. So information systems is one among many, many other disciplines that needs to work together in order to survive in this ever-changing environment. For example, we see the sharing economy with the rise of Uber, for example, and Indonesia Gojek. And we can see that this platform actually creating a lot of benefits to the user, but at the same time, there are so many problems that an information systems scientists could not be able to deal by themselves. They need, for example, ethics, whether it's right or wrong, to set the certain price, and then organization science about the decision making, mind and behavior of the user, and then built environment, space and architecture, and then law, lastly, but not least. So based on those background, I am now trying to implement this framework that I developed. I realized that this framework is, as we called, a framework, it needs to be fitted into a certain context. And I realized that the implementation differ across industrial sectors. I have tried from commercial sector or private sectors. Then I tried small and medium businesses, and then startups. But more recently, I am more, my research is conducted in the public sector. One of the main reasons to do the public sector is because I have access, and the results of the improvement can be felt by many citizens. So I'm trying to have or combine BPM and digital transformation. I use the case study from we called it Surabaya City Office for Population Administration and Civil Registration, or we called it COPAC. Now, what is the problem with COPAC? So basically, the problem is they don't really have a plan, a grand plan of how they conduct their improvement. These days, with the force, the enforcement by the government to transform into digital organization, they must be agile. At the same time, they are also required to comply with the rules. So they really face a lot of difficulties to manage the digital transformation, while at the same time adhere or comply to the rule and regulation of the government. So they did a lot of initiatives, especially during the COVID pandemic, when they transform everything that is done manually into online using an application they called Clampid. But the initiatives are all still ad hoc. I mean, normally they will come up with a certain idea and then implement it. And sometimes it is not being evaluated, and then they jump to another program or project. So based on this, my first student is trying to develop a software, a representation of how the program and project in the COPAC work together to achieve the organizational goals. We tried to create a dashboard, called BPM billboard. Now, this billboard will help the organization to really chart what is their goal or their strategic goals and how they implement it, and then later measure it, whether it has been achieved, and then carry on to the next. So instead of doing it very unstructured, in a very unstructured way, BPM billboard somehow let them have a very structured way of prioritizing what needs to be done. So let me try to open the billboard itself. So this is the representation of the billboard created by the students. I will just restart it. So it's actually looks like a dashboard. From the very start, the organization needs to put all the strategy here. Sorry, I didn't translate it into Indonesia. So for example, strategy. And then from strategy, they need to provide the context for each strategy. And then from that, they need to create strategy alignment and fill in the governance, methods and technology, and then people and culture. So let's say we are looking at the strategy. So here we can see that the COPAC CR actually has like 5 main strategy. First is try to improve their administrative services using information technology. And then there is also internal improvement process. They also try to create, they also have a goal to speed up the process and to make it easier And at the same time, they try to work with external organization to give innovation. And then finally, they also wanted to create big data for the population in Surabaya. So this is the strategy. Now, what do we do next? For the strategy, we need to provide the context. So, for example, what is the rule and regulation that empower the organization to conduct that strategy? So here we put everything that helps us realize what is the context of this implementation. Then here is, for example, in strategy alignment, they need to provide how that strategy is transformed into the business process. So the strategic alignment is trying to prioritize the improvement process, how to create an initiative that align with the strategy, creating performance indicator, and then collaborate and integrate the services. So let's click one of these. What happens in the prioritizing, for example? So here we can see how the strategy of one strategy that is called internal business process improvement is transferred into the capability. That means what the organization needs to do to achieve the strategy. So here you can see that to achieve the strategy, they need to prioritize their business process improvement and then create the project that will achieve that capability. So the project here is one other student that actually conducting analysis on the cycle time efficiency of the business process using process mining. Then, most importantly, this billboard also need to note what are the results of each project. So based on this, they can actually evaluate and chart whatever process, the project or program that they are doing, the contribution, and then whether it needs to be develop further or they need to start another project. So this is the BPM billboard. So I would also like to show you the result of business process data and information architecture and process performance measure and selection. So basically this the two project has been presented. I think one of the students is actually here. Titan is here. He's doing the number 3 process performance measure. But first, I will show the business process architecture, data and information architecture. So this has been presented in ICAXIS, an international conference in Jakarta, hybrid mode recently. So what is being done here actually, basically we are trying to map the process and the data. The government actually require every organization, public sector organization, to have a business process architecture and the data architecture. However, the business process architecture, they don't have it. They have sporadic in several areas. They have this so-called standard operating procedure, but not an entire business process architecture. So Hayu, one of the students, is actually creating this business process architecture. Then she also, this is, for example, the architecture. This is the level 0, so the top level of processes that the COPAC-CR is conducting. What is why an organization need this? It's basically giving you an overview of what you are actually doing, rather than just guessing. These are normally organization just have a organizational structure, and they do the business process according to gut feeling. But recently, the government asked from a regulation to create business process architecture. This is the example, and then this is the how it is developed into a very detailed business process model. And then later on, she also created the data architecture. And then the third project is creating improvement priorities and performance measure. Why? Because we cannot improve something that we cannot measure. Apparently, most of the, I think it's not a surprise, it happens everywhere. Sometimes we have a metrics that is so generic that we cannot see how one improvement in a certain business process will improve the entire metrics, or the metrics doesn't really relate to any of the business processes. So Titan, the students actually created this so-called process portfolio. So he first created the performance metrics and then collected the data. Based on the collected data, try to chart them. So for example, here, the vertical line is actually the health, I mean, how good the process is. And then the horizontal line is actually showing the whether the processes are strategically important or not. And then the color actually showing whether it is feasible to change the process or it's too hard because it's already being given by the government. So we can see here, for example, the birth certificate are included in the strategic importance, but their health performance is still low, and it is changeable. It's feasible to change it. So based on this portfolio, we can actually see that which one needs to be prioritized. So for example, moving out certificate is less important compared to the birth certificate because not a lot of movement compared to birth. And then also the moving out certificate is actually doing better in terms of their health or performance compared to the birth certificates. So basically, those are the 3 things that I would like to share. But at the same time, I'm also doing this, supervising the students to conduct a further study using process mining because they already have the IT system. So they have this data that we can collect and then map the actual business process. We are using one sample, that is the birth certificate. And then number 5 is actually doing the redesign with Lean Six Sigma. And then we also have a look at the culture. It's interesting to see that within one organization, different function in the organization or department in the same organization have actually different culture. And then we also conducted analysis on the complaint management process. And finally, we also try to help them discover innovation idea in a very structured way. Sometimes innovation idea comes out of nowhere because you just feel that it is something that needs to be done, but not doing it structurally. So at the moment, these are all finished. We are actually trying to move on with the next phase of the project. First, we would like to see the comparison between the original system with the new system, whether the user actually prefer it or feel that the new system is actually performing better than the last system. And then more processes needs to be analyzed. So with that, I think I would conclude my presentation and I will hand over to Bu Vivin. Thank you so much.
Okay, thank you, Ibu Mahendrawati, PhD, for the research talk. I hope that it can trigger us some new ideas about process science, BPM, and also digital transformation. So now again, I invite all participants to give give a text in the chat box to ask to Ibu Mahendrawati, or you can raise your hand. I think the question could be delivered in Bahasa Indonesia or English. Yeah. Okay, is there any question to Ibu Mahendrawati, PhD?
I think it's very clear.
Okay, then. This is Rani Pradina, maybe.
Yes, actually, there is something that I find very interesting. Actually, like I have been following your work since like 2010.
And we collaborate a lot during the numbered period, right, Bu Reni?
Yeah. So, well, actually, yeah, I remember, like the first when you worked on hospital logistics, and then it grew into, like, but I think it's very interesting, and I think very commendable, if I, like, if it's not very, like, I hope it's an appropriate word to say, like that. I think it's very interesting, and I'm something that I might say that I'm quite proud of you as a colleague, that, like it seems that your work has progressed into, something that's more clear, and in Indonesia it's something that's, like it's something that's, like it has a strong like idea and use in present use. And I was surprised to learn that actually the government has issued like how do you call it?
Regulation, yeah.
A regulation on that. So I think it's I would say it's like a testament for the, like the use of this business process management. What I would like to ask you is, therefore, what do you think about the future, especially since in Indonesia, like our problem is with, I think, with many process that's not very, like regulated or recorded and things like that. Where do you see it where do you think we can go from here, in terms of the, like in Indonesia we always balance between the applicability to our case in Indonesia, and
That's
also
true. Yeah.
trying to catch up with what's happening in the world. And I think that's very confusing. But
Yeah.
what do you
Yes.
say about that?
Thank you, Bu Reni, for breaking the ice and ask the question.
Yeah.
So actually, we can do this without the postgraduate research talk, right? So I need to say something to Pak Muklason. I think we need a different way of organizing this, because I think it's very hard when we are trying to encourage the research, the new research, to think about research, but during this kind of occasion, there are no interaction, which I think is not very common. So maybe a better way would be in the lab, for example, and then they meet each other, hopefully. So one day, hopefully, that will transpire. Right. Now, to answer Bu Reni's question, it's actually my question, because sometimes I thought, like, the government already mentioned about this, but it's not actually being done in reality. And also in the future, I think all of us are following what has been done outside. All the theory in the Western world doesn't really apply. Not all of them can be applied in Indonesia. And maybe it's not necessary. Sometimes we just like the idea. For example, many organizations said that they are moving to Industrial Revolution 4.0. Sometimes I just ask, are you sure that you are already in the third? I don't think so. So it's like we are so caught up with this. For example, here I have my former head of laboratory, who is very familiar with the work in the public sector. And he is the one that always said to me, please Bu, don't encourage them to create another IT. Sometimes the problem is not with the IT. And also my co-supervisor, Pak Raditya, also mentioned that they wanted to create big data. And I always think, what is the relevancy of big data? Big data needs five V: velocity, volume, variety. I don't know the other two V, but this is big data. And I'm thinking, where is the big data? Where is the necessity of creating that? Because I mean, citizen data, I don't think that will require such big data. I don't know. I don't think there is a birth for every second, or that needs to be put in the data, or I don't know. So basically, that's why I would like to learn more about business process management, because I want to learn the fundamental. I want to know what makes it difficult for them to think more holistically. Why is it always sporadic? Like, I need to create IT and that's it. And then tomorrow, another IT. I mean, all of us have the same problem, right? Today we have one KPI, and then tomorrow it will change. And then if we have a change in the leadership, everything will change again. So it's like we're circling all the time without trying to improve what we already being done. But I already have, I think, one answer. That is our mentality that always think about key performance indicators rather than process. We are more into getting our KPI, no matter what, no matter how. So rather than thinking about, okay, I would like to publish more, then I need to research more. So instead of doing that, we are trying to push whatever happens with the results and then trying to put it out there without really trying to think whether, for example, are we doing good research, for example. And then in the government, sometimes it's more about electoral, you know, this is election period. Sometimes it's more about how to get people excited, but in reality, it's different. So it happens everywhere, but it's more prevalent in Indonesia because of that. And also we like to see something that is tangible. So always company organization, if I talk about BPM, they will think, what is the point of charting all those things? It's not going to bring me profit. Of course not, because we are trying to improve the process. Then when the process improve, it should transpire into customer satisfaction, for example. But rather than thinking that, we try to shoot directly by, for example, using IT or many things. So Bu Reni, I think our future more on how we change the way we work to really actually think what are the root causes. Then for a certain root cause, maybe we don't need IT. We can just change the mindset, the organization, or the processes. On the other hand, IT is very important when it is applied to a certain with a certain goal in mind and manage carefully, I think so. But I really like the work that you are doing and Bu Vivin are doing, because I can see all the applicability, but I think the challenge is again how the stakeholders can perceive the importance. For example, you're doing a lot about natural language processing. It's very important for this Penduk Capil, because they have a lot of complaint and they would like to be able to do it, like to classify it and really assign this complaint to a certain person. So they already know that now. And then, for example, I mean, what Bu Vivin is doing is real, yeah. Although I don't think I can be your user Bu anymore with Bumil, yeah. But I think a lot of Bumil out there will be will be thrilled to have your application. So please go for it. And then don't forget that what you are doing, you need a lot of resources. Yeah, so sometimes we are in the environment where we have so many things to do, and we need the support that we have, and that sometimes come from the outside rather than the inside. Okay, so this is more about curhat rather than research
No.
talk.
Yeah, but if I may, I think the main key takeaway that I can gather from what you have just explained is that actually BPM is, like we should aim for a healthier process, which I think it makes a
Yes.
lot of sense. And instead of
The problem is to create a healthier process, we need time, and not a lot of organization has the patience to do that.
okay,
Yeah, they
well,
want direct results, profit, money, and investment in the time to create those processes, like to chart everything, what you're actually doing, who is doing what, and what are the artifact, the data that flows in and out of the process. That takes time. But that is compliance. Nowadays, the government is also pushing the organization to transfer digitally. So sometimes they chart their process, tomorrow it will change in the
Oh.
application. So they sometimes ask me, is it necessary to note it down, Bu? Because tomorrow it will change. And I think, yes, that is the challenge. How you create, how you still comply, but also very agile. When it needs to be
Oh, okay.
changed, you can change it quickly. Yeah. And
another-
that needs people that are agile. It's not possible when we said, oh, I want this done. Okay, I will do it tomorrow. And then tomorrow the process change again. So
Oh, okay.
it's never being done.
Oh, okay. So agility is seems to be like a key here to success here. I think maybe like I'm not sure if this is going off tangent too much, but I've just heard, like with things like sports and things like that. In Indonesia, we have this orientation of winning competitions when, like countries like more developed countries, let's just say that they focus more on, like having players which has, like good technical skills and things like that. And with that, they can actually what they can do with that is they can ensure that with time they will improve and improve and improve, and like winning competition is just like it's just like a side effect, you may say, of improving this process. So I think like you say, with like ever changing KPIs, that is something that's actually we shouldn't do. Maybe like we should try improve our process so that if we have we can ensure that we are improving all the time. So yeah.
Yeah, that's true. I mean, the KPI is important, but not the main goal. It should be bigger than just the KPI, because sometimes KPI is not defined based on the stakeholder needs. Yeah. So it's the same like rapport. Sometimes students or mark grade. Sometimes people are graded based on one aspect only when they have multiple intelligence, for example. This is the same thing actually. So, but I don't want to make us very gloomy with this, but I think we become so stressed. No, actually, when we realize this, we know that we need to improve somehow. And the only competition that we have is with ourselves. If every day we get better, then I think it should be good enough. Otherwise, we are stuck in someone else's KPI.
Okay.
I think
Thank you.
that's.
Thank you so much.
Thank you. Thank you. Very
Thank
nice
you.
conversation.
Thank you so much, Ms. Tanika Dinasti. Ibu Mahindrawati PhD. So it is an interesting talk between you, and I also listening very carefully, and I took some lessons from it. I think this is the end of the second research talk session. Now, come to our last session. It is rehearsal of our MS student, and before they present in the real international conference. So I'm trying my best now to be like a moderator, like in real conference situation. So two students, Faza and Bayu. Faza, are you coming right now?
Yes, ma'am. I'm here.
Okay. You have 2 minutes to present your research paper, and then followed by Q&A.
Okay. Thank you very much for the opportunity, Bu Vivin. Assalamualaikum warahmatullahi wabarakatuh. Good morning, good afternoon, everyone. Here I'm going to present the research Android-based chatbot application using backpropagation neural network to help the first treatment of children's disease. For the outline of the presentation, there are introduction and then literature review, methodology, result and discussion, and conclusion. For the first introduction, in the background of the research, in Indonesia, especially in the health sector, one of the problems is the level of child health. Based on Indonesian Demography and Health Survey in 2017, infant mortality rate or IMR in Indonesia reached 24 deaths out of 1,000 live births. And then the diseases that cause child death are difficult to treat at the public healthcare center or puskesmas level due to the lack of diagnostic tools and medicines. For now, the action taken by the Indonesian government is to create an IMCI, Integrated Management Childhood Illness or Manajemen Terpadu Balita Sakit program, with the aim of reducing morbidity and mortality from child death. But the implementation itself is not optimal because the healthcare center or puskesmas is not ready to accept the patient 24 hours a day. And then there is policies during the pandemic to reduce face-to-face contact, and it's required a lot of resources from the both side, from the patient side and the healthcare unit side. Nah, the parents need a quick way to find information about child illness. So it is proposed to develop a chatbot so that parent can ask their child symptoms and illnesses to the chatbot like a pediatrician. And then the parent can also take the early treatment for the disease, so there is no increase in the severity of the disease. Next, for the literature review, there is chatbot is an AI to mimic the way human chat and have conversation via audio or in the text form. And then next, integrated management of childhood illness or manajemen terpadu balita sakit is an integrated guide to handling sick toddlers to improve the health status of the children and the quality of the child health service. The procedure itself is by examining the disease through the question and answer, classifying the disease, and then taking action or referral advice. Next, natural language processing is a field of AI that allow human to communicate naturally with computer. And then for artificial neural network is a simple imitation model inspired by the working of the human brain. And then multi-layer perceptron, part of neural network that has been applied to a variety of tasks and problems such as prediction problem, function approximation, or classification problem. And then this propagation neural network that artificial neural network tries to find the smallest error rate by updating the parameter at the inverse rate. And then for the last, deep learning is used to solve problems such as image processing, speech recognition, and natural language processing. Next, there is methodology. First of all, study of literature. The output of this stage is to obtain the algorithm or method that used to solve the problem in this research, which is using a backpropagation neural network. Next, for the dataset processing, the dataset used in this project made from a reference book for the Management Terpadu Balita Sakit or IMCI, and was validated on the pediatrician in Ngumpak Dalam Health Center Bojonegoro using the interview method. Next, for the method design, was made to determine the workflow of the chatbot starting from receiving the message to providing the answer. Next, for the implementation, this space includes model training using a backpropagation neural network and designing a chatbot application according to the method design. For the Python package, there are TensorFlow, Keras, Natural Language Toolkit, and Flask. Next is testing. First, we do the model testing to determine the performance of the chatbot based on its accuracy and loss, and we do the analysis after all tests have been done so that we can find out the performance of the chatbot model. After that, we do the chatbot usability questionnaire to determine whether the performance of the chatbot is in accordance with the dialogue with humans, good navigation, intelligence, and according to their needs. And we do the result analysis. Conclusion are drawn from the result, comparative analysis of the accuracy of each test and the performance of the chatbot application in replying to message. Next, we talk about experimental result and discussion. First of all, the dataset. The dataset used in the model training based on reference to disease symptoms and treatment steps documented in the chart book of IMCI. There are 66 tag or label and pattern, and for training data 372 and 31 for validation data. There are 5 types of disease that use diarrhea, shortness of breath, dehydration, fever, and dengue fever. Next, for the model design, we do the feature extraction using the back-of-word method, which is done by converting text data into numerical vectors as features and calculating the occurrence rate of word against the corpus. We can see at the NLP flowchart. First, we do the data pre-processing, which is scaffolding, normalization, and remove stop word. And then doing the tokenizing, stemming, and the last step, the feature extraction back-of-word method. Next, we talk about the BPNN model that used in a sequential model. There is input layer depends on the number unique words that have been stemmed, 40, 101. For the hidden layer and droplet layer, based on trial and error, depending the result of the model test, and the output layer based on number existing label or text, 66 neurons. For the activation function, we have ReLU function for the hidden layer and softmax function in the last layer or output layer. Next, the training model, we do the training process, use the base optimizer and categorical cross entropy loss function. Next, about the chatbot application. The development of the chatbot application combines the backpropagation neural network as the core of the chatbot model and MIT App Inventor as the front end. We use the database PostgreSQL and using hosting virtual machine from Microsoft Azure. We can see at the application flow diagram, first the actor or user doing question and answering through the front end of the chatbot, MIT App Inventor, and send them to the back end of the application. The application doing the pre-processing data, tokenizing, stemming, back-of-word, and generate response and send them back to the front end so the user can read the answer. Every single conversation made in the application is recorded on the database. After that, we do the testing. First, we do model architect architecture test to determine the best model, the architecture by doing a grid search test on the PPNN model parameter. The indicator itself is the mean test score from the grid search. There are 5 types of optimizer, SGD, ada grade, ada delta, RMS prop, and ADAM. For the result base model architecture, we use ADAM as optimizer, and the first hidden layer there are 128 neurons, and the second hidden layer 64 neurons. We use dropout rate 0.5 and epoch 800, and we have the result mean test score 64.07%. After obtaining the architecture, base model architecture, we do the model training result, and we have the base model training result, training loss 0.11, and for the training accuracy 96%, for the validation loss 1.05, and validation accuracy 64%. Next, chatbot usability questionnaire that conducted on the parents of the children in the maternal and child healthcare unit at Ngumpak Dalam Bojonegoro Health Center. Respondents answer the 16 question with 5 category of answer, and we obtain the average of CUQ is 81.5, which is better than the acceptable value. This is shown that respondents think that chatbot have been used well and acceptable and useful. For the last conclusion, the backpropagation neural network algorithm can be applied as core model in the chatbot application for the first treatment of sick children. This statement can be shown by the result of the chatbot usability questionnaire, which is got average score of 81.5. Which indicates that respondents think that the chatbot can be used well, useful, and acceptable. For the base model BPNN, we got 128 and 64 for the hidden layer, with 800 training epoch, 0.5 dropout rate, and using ADAM as optimizer. We just got training loss value 0.11, training accuracy 96%, validation loss 1.05, and validation accuracy 0.64. For the last practical contribution that expected obtained from this research is that parents can use chatbot to act and provide initial treatment to their children. And the chatbot can be used by public health center or puskesmas in Bojonegoro to help improve child health level and reduce child mortality rates in their operating area. Thank you very much. And now for me, maybe I return it to Bu Vivin again. Thank you very much.
Okay, thank you, Faza. I think I still remember when you were defending your thesis. Yeah, I was one of your examiner, and Professor Arif Junaidi is also the lead of examiner of you. You were so brave back then, Faza.
Thank you, Bu.
So you will not get that common in the real situation of international conference. And then I will give you one question, maybe it is just my curiosity. Bayu, why is the training accuracy is very high? It is almost 100, right? 96%. But validation accuracy dropped to 64%. Why do you think that it can happen to your model?
Maybe it's because the model a little bit over the data that used in validation process is not enough. We back then we just have we must have the more data set in the data set, and the training model is not optimal.
Okay, so one of the causes is about overfitting, right?
Yeah, overfitting. Yeah.
Yeah, okay, thank you, Faza, for the answer. In the real conference, you maybe only have one or two questions. Sometimes they have no question or comments. So I will move to the next presenter, Bayu. Bayu is unable to attend this meeting, and he sent me a video of presentation. Like in the real situation of conference, you have two options to present your work, whether it is presenting live or you can send the video presentation, but you have to attend in person. So the participant who will ask the question can get the answer live. So I think you can see the video right now, but I will share the sound too.
Grow and I'm
So
invited
this
here
is
to
the presentation of
talk about the research with the title of Flexible Automated Course Timetabling System with Lecturer Preferences Using Hyperheuristic Algorithm. I did the research for my thesis under the supervision of Mr. Ahmad Bukhason. I'm so sorry that I can't join the Zoom meeting due to another agenda that I also need to attend. Okay, so I'm a class of 2018 information systems student, and there are also some of my experiences while in college that you can read. I'm gonna talk about 4 points in this explanation: the research background, literature review, results and discussion, and the last one is the conclusion. Okay, first is the research background. University timetabling involves various factors such as courses, lecturers, students, classrooms, and time slots. Course timetabling turns into a complex problem as the amount of the data determining the timetabling factor increases. Even a course timetable is designated as a non-deterministic polynomial or NP-hard problem. To solve course timetabling, various studies have been carried out with various algorithms such as genetic algorithm, particle swarm optimization, greedy simulated annealing, hyperheuristics, step-assisted hill climbing, etc. This course timetabling problem also occurs in the Department of Information Systems, where the course timetabling is still done manually. And moreover, its lecturer has different activities such as organizational position at the university or other organization. So the availability and preference of teaching time for its lecturer also needs to be considered. Seeing these problems, in this research, a course timetabling system solution will be offered using the late acceptance hill climbing algorithm based on hyperheuristic equipped with an interface in the form of a website. The existence of this interface aims to simplify the process of inputting datasets and constraints onlinely, which make it flexible to various timetabling conditions. Okay, we move to literature review. First is timetabling. Timetabling can be defined as a problem that focuses on allocating time and resources to meet as many constraints as possible. There are two types of constraints, namely hard constraints and soft constraints. Hard constraints are constraints that must be met because if there is a violation of the hard constraints, the solution cannot be accepted and applied. And the second one is soft constraints, which are limitations that do not have to be met, but soft constraints are related to the satisfaction, so it should be as many soft constraints as possible can be met. Hyperheuristics is a high-level search methodology that performs a search over the heuristic space. Hyperheuristics has a problem domain barrier, which is a barrier between the search strategy and the problem domain on which it is based. Research strategy will select and apply a low-level heuristic based on information from the search process. This low-level heuristic can also be combined in a collection of available heuristic into a single heuristic option. Let acceptance hill climbing algorithm. LHC algorithm is an iterated local search method based on a simple hill climbing optimization algorithm that will always move up to get the best solution. The way the LHC algorithm works is by delaying the comparisons of solutions by creating a list of current and previous solutions to a certain length, which is called the fitness cost rate. Okay, and then the results and the discussion. This is the course templating system is built from two major systems, namely the back-end and front-end system. The two systems will work together, where the process is initiated by the user entering course list data and constraints. The data will be stored in the database and converted in the form of payload data to make API requests to the backend system. This API will later be scheduled using the graph coloring largest degree method to find the initial solution and LHC to optimize the penalty that has been obtained. Finally, the results of the scheduling will be sent back to the front end and displayed to the user. And here is the homepage, and this is the course list page, course input page, and this is the second course input, which use CSV file, and this is the constraint, that time slot constraint, classroom constraint, semester constraint, lecturer constraint, and this is the timetabling result. Okay, next is hard constraints mathematical model, but I'm not gonna explain the detail of it, but basically there are three mathematical models for the hard constraint. And there are also two mathematical models for the soft constraints. And here is the test result. Table 1 shows that the higher number of iterations, the lower the average penalty obtained. However, in this test, it was found that several test processes at 100,000 iterations took more than 30 seconds and even experienced a server timeout. This is because the processing load to perform 100,000 iterations is quite big. Therefore, in this experiment, the number of iterations of 50,000 is the optimal choice because the average result is not much different from the 100,000 iteration and avoids the risk of server timeouts. In table 2 shows that the higher number of fitness cost array, the lower the average penalty obtained. And in table 3, the two optimization algorithms will be compared with the graph coloring algorithm, which is used to generate the initial solution before optimization. The result is the LHC algorithm can optimize the initial solution better than the HC algorithm. In addition, the HC and LHC algorithms also have different penalty reduction patterns, which the LHC algorithm can reduce penalties faster in the initial iterations in both odd and even semester datasets. Okay, and the last is the conclusion. First is the hyperheuristic based lead acceptance hill climbing algorithm was successfully implemented into a course timetabling system that is flexible towards lecturer preferences and has been tested on the dataset of the Information Systems Department of the Institute of Technology 10 November Surabaya, for the odd and even semesters. For the 2021 until 2022 academic year, with a website-based interface to make it easier for users to do course timetabling, both in terms of entering course data, constraint, and viewing timetabling results. And the lead acceptance hill climbing algorithm with a fitness course array of 10,000 and 50,000 iterations provides optimal and consistent results while still paying attention to the server resources and processing time needed to maintain comfortable use through the website. The lead acceptance hill climbing algorithm produces a more optimal penalty both in odd and even semester dataset compared to the penalty value generated by graph coloring and hill climbing algorithm. For future research in a website-based system, the comparison of algorithm can be complemented by measuring the server load when processing, so that the efficiency of the algorithm in server resource use can be seen. And that's it. Thank you so much for your attention. And if you have any question, you can contact me through email and LinkedIn that I saw here. Thank you once again.
Okay, since Bayu is not here, so I would not give any direct question. So dear participants, on behalf of IS department, I would like to say thank you also for Bayu and Baza. I wish you the best luck for the real conference. You've presented very well today, and see you in the next series. I'm Retno, signing off from this research talk. Wassalamualaikum warahmatullahi wabarakatuh.